We're back. My name is Jason Stankiewicz, and I'm currently a second-year Pulmonary and Critical Care Fellow at the University of Maryland. We're pushing on in our nicotine use treatment series. After some necessary background information on the last sections, we're going to learn today to apply methods that can effectively intervene on our patients who use nicotine. These images all link together, the basics and overview for today. So we're not going to exhaustively do so, but we're going to briefly outline how we can target behavioral effects in our patients who use nicotine and better understand how methods are applied to intervene on such behaviors. Our targets for today will include 1, the basic understanding of counseling and nicotine use treatment. 2, reviewing interventions to help promote willingness to quit. 3, review interventions to help promote nicotine use quitting in those willing to quit. Wow, what an overwhelming image of our patient's waiting room. But really, I show you this image to emphasize a real message. That's the profound and unique potential we have as healthcare providers. According to data from Leone and colleagues, there are up to 1 billion patient interactions annually in the U.S. healthcare system. Also, about 70% of smokers will see at least one physician per year. These stats call to my attention ways that I can help or intervene. Furthermore, it's been stated that up to 70% of current smokers wish to quit. Believe it or not, current smokers hold in high regard our opinion as physicians for their well-being. As a result, the mere asking and assessing a patient's nicotine status is vital at 100% of these visits because it opens the door to conversations and it prioritizes our care for this addiction, a conversation that could lead to potential therapies with efficacy. As an aside, to get slightly more nuanced than does your patient smoke, vape, or use nicotine or not, it may actually be helpful to quantify the addiction relationship. There are several clinical tools and calculators are all listed here. But besides being cool for knowing a scale name such as HONK, we will see that these tools will have implications for how intense our therapies may be, for nicotine replacement, for pharmacotherapy, for counseling. Some have proposed that a simplified approach may include whether or not our patients smoke less than 30 minutes, which may be more intense addiction versus greater than 30 minutes upon awakening. It's really a simplified form of the most commonest tools, including the modified Fagerstrom test for nicotine dependence listed here. Perhaps it's an artificial dichotomy, but some groups propose we identify and focus on different groups in different ways, based on the answer to the question of, so, are you willing to give quitting a try? Namely, perhaps we should group those who use nicotine as 1, those who use nicotine, who are currently unwilling to make a quit attempt, versus 2, those using nicotine who are currently willing to make a quit attempt. The theory is that we should perhaps more efficiently direct our energies into ways that nicotine users may find helpful. We should not be in the mindset of lecturing, but really meeting the person where he or she is in their journey. In those nicotine users currently unwilling to make a quit attempt, can we do anything? Let's just call them pre-contemplative and move on with our days. But is this really the best we can do? It's probably better to try to understand them from an ambivalence perspective. Ambivalence, as Leone states, that we should really know as an approach avoidance behavior. Remember, those with nicotine addiction often are struggling between 2 different not-so-great alternatives. 1, to smoke, and that would mean to continue to lead on to those toxic effects of nicotine and tobacco in our systems. Or 2, to not to smoke, which is to fight against that basic survival mechanism, the safety signal that nicotine employs by hijacking the mesolimbic dopamine-based pathways, and really without it, leading to a state of withdrawal and abstinence. After understanding what our patients may suffer from in ambivalence, perhaps we can begin to approach from a place of help. This is really highlighted by motivational interviewing, or MI. And MI is generally a psychotherapy method focusing on communication. It's a way to talk with our patients. In many ways, MI is the opposite of starting off by lecturing about how terrible smoking is, and that you should spend more money on food, and that if you didn't smoke, perhaps you would have less sputum production, which may be led by, I don't care about that, or that won't matter to me. Instead, MI is a way to achieve that change in a patient by meeting them where they are and gradually leading to a goal. By attempting to tap in to that patient's feelings, beliefs, ideas, and values regarding nicotine use. Once we tap into that language, we can begin to, in a concrete manner, put words to that ambivalence and talk about it and get it out in the open and start making some change and commitment language. In the office, this can really be employed as brief interventions. So as to avoid sounding too abstract or philosophical, Here's a mnemonic, and this is the 5 R's, which include key components to include in a motivational interviewing section. And that's relevance, risks, rewards, roadblocks, and repetition. One is relevance, and that's encouraging the patient to say what makes quitting nicotine use so very personal. And that could be in terms of health, age, family. An example might be a patient willing to quit and motivated to quit because it would allow them the chance to spend more time with their grandchildren. 2 are risks. So that's seeking out what the patient perceives the risks to be to them in continued nicotine use. And that could be acute, that could be long-term risks such as sputum production, COPD exacerbations, cancer risks. Some might even find it hard to really begin to depend on others as their nicotine use becomes more and more aggressive. 3 are the rewards. So that's asking how patients identify the perks of quitting. This may be in terms of health, finance, perhaps just general well-being, and maybe even appearance, those appearances of their teeth, their nails, their general smell over time. 4 are the roadblocks, so seeking out how patients may be worried about the pitfalls or shortcomings and be equipped with tools to help with nicotine abstinence. That may include abstinence fears, withdrawal fears, weight gain, side effects of pharmacotherapy, and so on. Lastly, repetition. It's repeating in 100% of these visits these methods, including those unmotivated to quit. Let's discuss those who are willing to quit. We can direct our efforts differently. Notably, these efforts can be brief as 3 minutes can be effective in a busy office setting. Note as well that more intensive therapy probably equates to more effective therapy. Additionally, it's been noted that combining counseling to pharmacotherapy is probably the most effective, as we should also be flexible because some patients may prefer one method over another. But to get into the practical or problem-solving skills training, here are a few notes. One is a technique of recognizing danger situations. So this tactic involves preemptively warning patients and equipping them with the knowledge to see certain emotions and activities that may increase risk of relapse and avoidance behaviors. This may be noticing social cues such as I only smoke when I drink and being cognizant of when urges occur. 2 are developing coping skills. This refers to empowering nicotine users to deal with these risky situations when they arise, and that may be anticipating urges and dealing with them in terms of nicotine lozenges or perhaps distraction and behaviors to avoid urges. 3 is providing basic information. Of course, we probably do this on a regular basis, but then this information is important because it eliminates any myths about treatment. And it may include myths about withdrawal symptoms, how they present, the time course, and so on. Without such basic information, that ambivalence is going to continue to fuel. The second-pronged approach is really providing a supportive treatment. And that's honestly, effectively being a good, caring person and doctor. Specifically, that's encouraging the patient with a focus on hope that we have many effective treatments and that you, the patient, are not unlike many others in the world, and they've been through this. This may include baby steps of progress, which can really help tackle that Herculean task of quitting smoking. All the while, really communicating a caring and concerning approach to express the willingness of yourself as a provider and your team in asking about what's troubling the patient at the time. And lastly, it's important to encourage the patient to continue to talk about reasons of quitting, concerns, and difficulties. As a whole, counseling can include many methods, as we'll go into, including person, telephone, group, and individual. So what resources can we provide besides office-based counseling? One would be websites. So I'd encourage you and your patients to check out smokefree.gov. It's chock full of resources. 2 are the quit lines. So I think there's some mystique surrounding quit lines. That is, what's the number? Who's going to answer when I call? Is it going to be a human? Is it going to be a robot? So if you don't know, these lines function, and how they work is one would call a main phone number, that's the 1-800-QUIT-NOW, and they would be forwarded to their state quit line. Oftentimes, this results in free support, and get this, a human quit line coach who offers personalized plans, practical information, literature, and often free or discounted medications. It's really amazing. The North American Quit Line Consortium started in 2004, and they've done awesome work since then. There's a quit line in all 50 U.S. states, and these quit lines are open at least 5 days per week, 8 hours per day, and sometimes they're even open 24/7. What they offer are often counseling sessions, single sessions, 10 minutes or longer, and those could be activated by the caller or reactive situations, or those could be activated by the counselor or proactive situations. What's cool is that there's several specialized personal counseling groups, and those who smoke and who are pregnant, who use smokeless tobacco, those who smoke who happen to be older or younger, those of racial or ethnic groups, those with chronic mental and or medical conditions, those young adults, those LGBTQIA community members, those with low literacy. So really touching many unique bases. A meta-analysis by the Cochrane Group in 2019 demonstrated that there was moderate certainty evidence that proactive telephone counseling aided smokers who sought help from quit lines. And there was also moderate certainty evidence that proactive telephone counseling increased quit rates in smokers in other settings. We are always on our phones, and that's okay because we can use that resource, that fact, to tap into other nicotine use treatments. One are texting services. There's one called Smoke-Free TXT, whereby you can text quit, the letters QUIT, to 47848. That's quit to 47848 to enroll in a 6 to 8 week text message service system. And that consists of about 3 to 5 messages per day, and they're customized based on different programs or input provided by the user. And they could be also including in specialized certain communities as outlined previously. There's a Cochrane review in 2016 that demonstrates efficacy on 6-month cessation outcomes in this regard. 2 are smoke-free apps. So there's several. If you go on your app browser or directory, you're going to see a slew of different apps. There's really 2 prominent ones I outlined above, and they're the Quit Start app and the Quit Guide app. So Quit Guide, it models and it helps the user understand smoking patterns, cravings, practice to get tips, and allows for journal entries on urges. 2 is the Quit Start app. Monitors progress. It also monitors cravings and manages cravings, and it helps develop cognitive tools, including those of distraction. All of these are generally free. As I mentioned above, take a look at your app browser and you're going to see a ton that will likely work for some of your patients. I hope that in conclusion, we can begin to appreciate ways to help motivate our patients to stop using nicotine in very practical ways, including the office-based motivational interviewing, the 5 Rs, other office-based tools, including being aware of risk scenarios and general supportive care, as well as those out-of-office quit lines, text lines, and cell phone-based apps. So in conclusion, I really like to thank you for staying tuned and really look forward to next week as we discuss the counterpart to counseling, and that's pharmacotherapy. Thank you again and take care.